What I want to do is talk about misperceptions that I've had for the past 40-some years and how it's led to changes of how I've looked at poverty and disaster relief and international health. So let me start with some background. I'm from a town in West Virginia, grew up there in the 60s, which was pretty much like being Opie and Andy of Mayberry. It was a great place to grow up. It sort of reflects my cultural bias. And it wasn't a bad education. I got a chance to go to college where I was really interested in how people use their environments, especially marginalized populations. That lasted about a year. I wasn't quite ready to sit in the classroom. I had a professor who wanted somebody to go collect plants in a fairly remote area. It was going to be a 3-week trip. It turned out to be about 4 years. This is where I ended up, and it was pretty clear I was no longer in Mayberry. It was a great experience. I had the best time of my life, came back to the US, and went to graduate school in international development and Asian studies, and became totally unemployable. Trying to figure out what to do next, I did what everybody else did. I applied to medical school, and ended up, I'm an internist and geriatrician, but always had an interest in public health and tropical medicine. So that's the perspective of what I'm going to talk about today. And I'm also going to say that being old in the United States or being poor in the United States isn't really much different to some degree than some of the problems we're going to talk about. So let's look at some of the misconceptions we've all had. This is what we were taught in school. Columbus discovered America. We were all taught this. It's a very Western-centric view. For about 15,000 years, there was an indigenous population. They knew where they were. They didn't need to be discovered. So next, this is what we're taught in medical school, and it's a lot of what people think. We think that we've made incredible technological advances in healthcare, and that's what's led to our improvement in health. It's not true. If you go back 100 years, the average life expectancy in America was less than that of any country in the world today. The advances that were made were clean water, better food, better housing. We get into the 50s, we get immunizations, and we do things like don't smoke, wear seatbelts. It's basic public health. That is never to take away from the medical advances that we have. So let's get to one that'll make us squirm a little bit. Poor people are lazy. We don't really believe this, but yet it's really in our political and social dialogues today. We really get the sense that a lot of people think that poor people are lazy. So I'd like to look at some misconceptions that I've had about poverty. I'm not even going to talk about the $1-a-day people. I'm a generous guy and I'm pretty optimistic. Let's go right to the $2-a-day people. What this is supposed to reflect are people who lack the access to food, water, shelter, basic security, and any rudimentary health care. This is 2.8 billion people, or almost 40% of the world today. And I think we're doing this all wrong. I think we have to stop focusing just on the $1-a-day or $2-a-day measurements. And we have to look more at what do those signify. So for the $2 a day, what I think is more important would be access to education, the ability to work in a safe place, gender equity, human rights, and the ability to attain one's human potential. I'd like for people to see what this looks like on the ground. This is a family in Nepal, 5 people, 2 children, 2 parents, and 1 grandparent. They own their own home. They have electricity hooked up. The electricity works maybe 3 to 4 hours a week, maybe. The children are going to school. The farmer is growing rice to feed himself and potatoes for a little extra crop. They're doing okay. Let's go even more remote. This would be a fairly remote area in the Kingdom of Bhutan. They're outside the market economy. Housing is excellent. They have universal health care. The government provides everybody with a cell phone that accesses the police and the clinic, and there's an emergency access if they need it. All children are going to school. They immunize better than we do in the United States. But they're not at the dollar a day. So here's middle class. This is in the Philippines. They're making $4 to $5 a day. They're scavenging on a toxic waste dump. It's an intact community. They own their own homes. They're living together. It is a very intact community. They have a basketball court. Children, they're cute kids. Everybody's living together. Kids are coming out to play. It's a pretty great place. But you realize that there's no access to education for these kids. There's no access to water. The kids aren't going to do very well. If you look at the environment, they've all got eye disease and lung disease. So we need to move beyond that simple monetary view and ask, what does it mean for people as individuals? So I'm going to move on to that from that misconception. And let's go a little further. Poor people are not lazy. I think it takes incredible resilience and resourcefulness to be a disenfranchised population living on these marginal edges of society. So how do we talk about it in public? Teach a man to fish and he is fed for a day. So let's start with this. We know this isn't right, but we can't help ourselves. We keep giving them fish. We walk into villages with duffel bags of donated clothing, teddy bears for orphanages. We walk in with donated medications. The doctors set up a clinic. We pass out meds for a day, pull a couple of teeth. We'll walk out, we feel really good. On a larger scale, the agricultural surpluses in this country may be dumped in Ethiopia. And people there need the food, but it may be timed when the farmers are bringing their crops to food, bankrupting the local farmers because you've collapsed the economy. So let's go to the bottom part. Teach a man how to fish, he's fed for a life. Let's start with a basic thing. Why aren't they teaching the women? The women are the ones in charge of this, and they're the ones who are going to be cooking the fish anyway. But it should go beyond this. I'm going to say people know how to fish. The knowledge how to fish exists. What they don't have is they may not have the ability to access the river. The river could be polluted. The fish have been depleted. The river's been dammed. If you can catch fish, they don't have the transport to get it to the market. If they can get it to the market, they may not be the ethnic group that can sell it. So at this point, the knowledge to fish exists. What we may need is to focus on the ability of this population to obtain the economic and political ability to be able to deal with environmental degradation, deal with the social inequities and the misappropriation of resources, and be able to attain those steps towards human potential. They're going to do it if we don't make it worse. So I want to go to the one problem that I think is the one I'm having the most trouble with. Many of us who first work overseas and still work overseas are doing one of these three things. The acute disaster. I'm going to try to clarify what I think is going on, though I'm going to say I don't think most aid agencies, much less volunteers, know this. An acute disaster is an event. This would be the earthquake in Haiti. It would be the tsunami in Southeast Asia in 2004. I think this event occurred and it's over with in 3 days. It's done. Either you've lived or you've died. And the only people who can really respond to these situations are very large military groups or a few trained specialists who can come in completely self-sufficient, food, water, shelter, power, and set up mobile hospitals. But we still get asked to go to help with the Haitian disaster. And I'm going to say that's not what people are doing. It's a nice hook for donation of money, but it's a misperception. So the next thing that we have is the humanitarian crisis and the relief work. I think that's actually what we really do in these situations. And those are the situations where you're trying to get in basic access to water first, food distribution, appropriate shelter as fast as you can, and try to prevent the diseases that might emerge in these things. I want to show you what this might look like on the ground. This is the 2004 tsunami in Indonesia. Many of us think that Thailand was the main country that was affected. It actually was the northern part of Sumatra in a province called Aceh. It's estimated that 150 to 180,000 people died, probably in 2 minutes. And so people like me go, I thought it was pretty good. I can speak a little Indonesian. I knew the area. And I walk into this after 3 to 4 weeks. There's nothing I can do. This is absolutely something where we've had no skills, no training, no experience, and with good intentions, we go to help. What we may end up doing is taking away the food, water, and shelter of the people who are remaining. So let's see what things look like after 6 months. Let's go to a different place. This would be a refugee camp on the border of Nepal and India. These would be the Nepalese refugees from Bhutan. They've been there since the 1990s. They're building housing developments. So when we think we're going to do humanitarian aid or disaster relief or humanitarian crisis work, we actually may be doing the international development and community building that started before the refugee problem and should continue afterwards. If we don't know what we're doing, if we can't make the right diagnosis, we're not going to be able to match the skills for what's needed most. Every year, about 12 million people are dislocated from wars, famines, or disasters. At the same time, every year, 10 million people are being relocated by things we think are good. Urban transport systems in developing world slums, septic systems, building dams for hydroelectric power. But the people who do get moved from these settings tend to be the ethnic minorities and the disenfranchised. It's become, in some cases, so targeted that it is called developmental cleansing. We actually don't know the outcomes, but we do this because we think it's good intentions. We really are trying to help build the systems within these cities. So what do we do now? By the way, Curie Larsen, I think, has done more for parasitology than any author I know. What we need to do is figure out better ways of doing this. And I'm just going to go through a list of mistakes that I've made, and I'm going to try to be a little optimistic at the end. In terms of service, what we need to start doing is working with people on the ground, finding out what their needs are. What do they want? Instead, what we've done in the past is we've taken our skills and interests and bring them to these folks. We absolutely need to get the sweat equity of the people on the ground. We shouldn't be doing the work if they can do it. We need to be able to just bring some additional skills and teaching. This may even go so far for us in medicine of no direct care any longer. Maybe we shouldn't be seeing patients. What we should do is teach the local healthcare provider. By the way, there is always a local healthcare provider. You work with them, you build their confidence, you build their skills, and that in turn is going to make the local villagers have more confidence. They're not going to wait till the next group of doctors coming through with duffel bags. When we look at the issues of sustainability, probably one of the most overused words in development, sustainability is part of this. We shouldn't keep bringing in equipment from our country that hospitals are donating because they can't use them. They can't repair them. They can't fix them. And if you go behind many of the hospitals that we've worked at, there's dump loads of donated equipment that can't be used. If you also are doing this in a sustainable manner, you're going to have the local population, the local clinicians, the local healthcare system be able to follow up on patients that you've tried to work with. If somebody comes in and provides surgery, but you don't have anybody who can follow up, you may have potentially done harm to patients. So the sustainability means building up those local resources and stop focusing on our needs. The professionalism part is something everybody violates every day on every trip. We are no more licensed to practice medicine in Bangladesh than a Bangladeshi is able to practice medicine in our homeless clinics. The needs may be identical in both countries. We're not licensed. We need to get past this. We need to be able to work with the local healthcare systems. We always need to be able to build up the local capacity. The other thing I think that is a mistake is we sometimes settle for less. The goal should always be aim for care equal to what you'd expect in your own country. So there it is. Develop the skills of the locals and focus on their needs, not your own. So the other thing we want to do, we want to be transparent. We have all made horrible mistakes. They're all with good intentions, but it's with the idea of trying to help people. What we should be able to do is talk to other groups. What's been a failure? What's been a success? Start cooperating with numerous groups. In Aceh in Indonesia, there were 8 groups crawling all over each other and nobody knew quite what to do. There was no coordination. We need to be more transparent and cooperative. So I said I'm an optimist. I want to give you one example of something that did work. Nepal has been in a civil war for about 25 years when we first started working there. There was a community that they were pretty marginal. These were the less than $1 a day folks. And we worked with some local populations and said, what is it that you need? That took 3 years. And they decided our biggest problems are crop production and bad water. So we worked with them a little longer, and we came up with introducing simple technology called biogas converters. Let me just walk you through this really quickly. This is going to be an enclosed pit. The toilets will go into this pipe. The sludge at the end you can actually shovel out and throw in your fields. It will be free of human pathogens. It's a pretty slick thing. When we started out, it was about 80 to 90 bucks each. But we didn't want to do the pits. That's their job. Well, they were smarter than us. They figured out how to do this fairly cheaply. This is what it looks like in the end. And here's what that first house that we looked at looks like from the inside. Not much, but here's what happened. Unintended consequences. The methane is piped off, so now she can cook. There's more fertilizer in the fields. Crop production went up. Nutrition went up. People could work more because they were healthier. We suddenly separated the sewage system from the drinking water. Less diarrhea, kids can go to school. The other thing that happens is that these women, and always the girls, would have to go off into the forest to get firewood for cooking. Different communities would be marching up the mountain and competing over forestry resources. Now they don't have to do that anymore. The girls don't have to walk 2 hours a day to collect wood. They can go to school. And actually there's less eye disease and lung disease because there's not smoke inside the house. Now, this is a small solution. It worked here. It did not work in a community over the ridge yet. We'll see what happens in the future, but we need to keep trying. We have the same needs in the United States. If we can simply maintain our passion, our empathy, and that generosity of spirit, we'll be able to do the same things here to help that we can do overseas, and we need to keep trying. Thank you.